really important things. You don't make antibody against the agglutinogens or markers on your red cells that you've got, but you do make antibody or agglutinin to the agglutinogens that you don't have on your red cells. You've got to remember that. If you're type A, you have A agglutinogens on your red cells, but you won't have antibodies to agglutinin A. But you will have antibodies to the agglutinogen B, because you don't have that marker. Got to remember that. Okay, 4 blood types. Here they are. Type A, right here, A markers, A agglutinogens. Jump over to type AB. You inherited an allele. One parent gave you A blood allele. The other parent gave you B blood allele. You've got both markers. Type O, no markers. O is not an actual marker. There is no O agglutinogen. O means the absence of A or B. Alright, the antibody that you've got. Let's start with the type O person. You have no agglutinogen of A or B on your red cells, but you're going to have both antibodies. Your immune system makes the antibodies to the markers you don't have. You've got both anti-A and anti-B. The person with AB blood has neither. They have both markers. Their blood would clump or agglutinate if they had either antibody. The person with A blood is going to have anti-B. Now at the bottom, you see the 4 major blood types. You can see that O blood is the most common and A is the second most common. This varies with ethnic groups. Okay, we'll talk about who can give to who in a bit. Alright, spontaneous antibodies. This type O person right here at the end, even though type O may have never ever in a million years gotten any blood of any kind, from about the time they were 6 months old, their immune system was making anti-A and anti-B. That's why they're called spontaneous. You don't have to be exposed to the agglutinogen for your immune system to make the antibody to it. We'll talk more about universal donor and recipient coming up in a minute. Okay, here we are. So, the key thing is this first statement. What you have to think about when you're trying to decide who can give to whom is the markers, the agglutinogens, on the donor's red blood cells, that is the donated blood. You have to see if there will be a compatibility with the recipient's antibodies that are in their plasma, the agglutinins. So in other words, you're going to give A blood to an O type person. The recipient is O. The recipient's plasma has anti-A and anti-B. You're trying to give A blood cells in the donor's blood. Those A blood cells have A agglutinogens. There is an incompatibility. The A markers of the donor react with the agglutinins, anti-A, in the recipient. That means you can't give the blood. Let's say, let me activate a whiteboard here. And nope, I don't want that little guy right there. Okay, so let's go with this. Alright, so we have a donor. Sorry, can't draw very well here. Who is A. We have a recipient. Let's make them AB. Alright, so question about the donor. What little agglutinogens do they have? They have A all over their cells. Okay, recipient, in their plasma, what antibody do they have? Well, they don't have any because they have both agglutinogens. They can't have the antibody to either one. Now, there is no incompatibility here. We can give that blood to the recipient AB. Okay, so let me change this. Let me make this bigger. Okay, so here is my donor. And this time, let's give A blood to the recipient, who's going to be O. All right, remember the markers on this guy's red blood cells. A. What kind of antibody does this O person have? They have anti-A. They have anti-B. This antibody right here is going to cause a problem with these markers. You cannot give that blood. Let's change this. Donor, recipient. Let's give O to A. Okay. On the red blood cells of this O blood, no markers. In the recipient, who is A blood, there is anti-B. We don't care. There are no B markers on the red blood cells. You can give that blood to that person. Not a problem. Okay, let's do one more variation. By the way, you can give blood of O type to anyone. That's why they're the universal donor. They have no markers, no agglutinogens on their red cells. All right, this time let's give A blood to an AB recipient. All right, A blood got A markers. And the antibody in the recipient, no problem. You can give this blood. And that's why the AB person is a universal recipient. They do not have antibody. Okay, so I've defined universal donor and recipient. Let's get out of this. Let's go back. Let's see. Okay, so these are just the people that can give to whom. We'll work some of these in class out. Oh, I know, there was one more thing that I wanted to talk about. Look at the second statement. You may be thinking, well, wait a minute. In a pint of blood that we're going to give from the donor, there would be some antibody in there. Don't we have to worry about the agglutinogens, the antibodies of the donor blood, with the agglutinogens of the recipient's blood? No, not really. And the reason why is in blue. There's very little antibody in donor blood. They usually give concentrated blood with very little plasma in it as donor blood. And so there's virtually insignificant amounts of antibody. This is not a problem. It's the first statement that's the problem. Okay, so cross-matching. I need to talk about that. Remember that there's more than just ABO blood typing. There's RH, which we're going to talk about, but there's also a variety of other ones. There are over 30 different agglutinogens you can have on red cells. So let me show you cross-matching. We have a donor. We have a recipient. The donor has got A blood. The recipient has got, let's say, their A blood. All right, now it looks like they would be fine and dandy. But remember, there are other agglutinogens. There's N and M agglutinogens. There are a variety of different agglutinogens that we don't normally do typing on. So what we're going to do is we're going to do we're going to take some of the blood. Here's a tube of blood of the donor. Here's a tube of blood of the recipient. Down here at the bottom is the settled out red cells. You know, we spin it down in a centrifuge. So here's the solid blood down at the bottom, blood cells. Okay, now up at the top is the plasma. All right, remember plasma up here. That's where the antibody is, right? Antibody is floating around in the plasma. Agglutinogens are down with the red cells. Okay, we're going to take a microscope slide right here, or whatever, card. Okay, now we are going to take, let me change colors here to blue. Okay, so we're going to take a drop of the blood with the agglutinogens, and we're going to add a drop of the plasma that would have the antibody. So if there's any antibody here that would react with any of the other agglutinogens in the donor cell, we would get a reaction. That's what we're looking for. We're looking for an agglutination reaction. Then, just to make sure, going both ways, we're going to take blood cells from the recipient, which would have, again, the agglutinogen. We take a drop of the plasma, which of course is where you find the antibody, and we look for an agglutination reaction that way. So we're cross-matching. If we get an agglutination in either case, we would not give that blood. Alright, that's cross-matching. Okay, but let's say you give the wrong blood. Now you have a transfusion reaction. Alright, so here we've given the wrong blood. You see the donor blood that is red blood cells, and it's put into the body of the person, and let's say there's antibody, and we now get the reaction between the agglutinin and the agglutinogens, and we get an agglutination reaction. You see it clumped up red blood cells. I showed you a card that had reactions on it. In fact, let's see if I can go back. Let me go up. There we go. So on this card you see 3 agglutination reactions. You see how the red cells are pulling into a clumpy like lattice type of arrangement. Alright, now these red cells are going to be destroyed, so at the very end up here where it says organ damage, you see that the red cells have been destroyed. These accumulate in the blood vessels. They cause the blood to be obstructed in the blood vessel, and this obviously means that there's not going to be enough oxygenated blood or blood supply getting to whatever organ this is all happening in. The symptoms vary. Usually you'd be tired because you're not getting enough oxygenated blood to the organs. You'd be anemic because the red cells are getting broken down. You would probably get some jaundice because when the red cells are broken down, they release heme, and heme is then ultimately broken down to bile pigments, bilirubin and biliverdin. In addition, you can have severe symptoms like kidney damage because the kidney clears blood, and it gets overwhelmed with these clumps of blood agglutinated areas, and it just ceases to function. And then you can have other organs that are damaged too. Causes of death, usually kidney. But this is not quick. It's not like you get a bad transfusion and 24 hours later you're dead. Usually it takes a couple of weeks. By then the person's gone to the doctor, they figure out what the problem is, they give them good blood. Now you can avoid all this if you give your own blood to yourself. It's called an autologous transfusion. So if you knew you were going in for, I don't know, breast enhancement surgery in a month, you could put a quart away for yourself in case you needed it. Okay, Rh blood groups. You notice that little red arrow that came and it went? That's important. And you can see it right here where it pointed to. Whereas in antibodies to A and B agglutinogens, those are spontaneous antibodies. They're made from about the time when your immune system starts to kick in when you're a baby at about 6 months, 5 months. In the Rh blood group, you've got to have prior exposure to that Rh blood. Okay, so most of the population is Rh positive, and that means that on your red blood cells, there you are, you've got Rh markers. All right. So that's Rh blood. That's all it is. Now, you would not have anti-Rh agglutinin antibody running around in your blood. It would clump your red cells. On the other hand, if you are Rh negative, on your red blood cells, you don't have anything. Now, you would think, according to Landsteiner's law number 2, which said that your immune system makes antibodies to the agglutinogen you don't have, that this Rh negative person would make anti-Rh, but they don't, because in the Rh blood group system, it's different. You have to have prior exposure. So you had to come in contact with Rh blood, positive blood, somewhere in your life in order to make anti-Rh. Okay, so in passing, notice that there are 3 different Rh agglutinogens, C, D, and E. D is the major one. If you have any of these, you're Rh positive. Okay, now, the big problem here. What can happen? If you give Rh positive blood to an Rh negative recipient, you can do it once if they've never come in contact with Rh positive blood. But if they already got Rh positive blood one time, they have antibodies, and you can't give it a second time. Antibodies last for a lifetime, by the way. Now, the big problem is the second scenario that we're going to talk about, the Rh negative mother who has an Rh positive fetus. Okay, here's the scenario. Get rid of that. Oops. I was trying to get rid of, there you go. Alright, so this is hemolytic disease of the newborn that I'm going to talk about. You got a mom here. She is Rh negative. Her immune system has never seen positive cells. Remember, she is carrying an Rh positive baby. Those fetal cells have that agglutinogen. Now, this is not a problem. Remember, this is her first pregnancy. There's no exchange of blood between mom and fetus. The only time that there might be, or is, would be at birth, at labor. There's an umbilical cord attached to the fetus. It's got fetal red blood cells in it. Attached to the umbilical cord is the placenta. It's attached to the uterus of the woman. When it starts to rip off, there's going to be leakage of fetal cells. You know, as the baby is out of there, going out of there, there's going to be leakage of Rh positive fetal cells into the mother's supply. Now, this alerts her immune system, and she is ultimately, unless it's prevented, she's going to make antibodies. It's going to take a couple of weeks for her immune system to kick in and make enough of these antibodies to the Rh positive. Now, think about where that first baby is. He's out of there. This is not a problem for him. The problem is with the second Rh positive baby, because mom already has antibody, and that antibody will go across the placenta into the fetus and destroy fetal cells. Now, you're wondering, well, why do those antibodies cross? You probably already know that in the last trimester of pregnancy, antibodies in the mother cross the placenta to the fetus, and they're protective antibodies for the newborn until his own immune system kicks in. But along with those good antibodies go anti-Rh. That's the problem. So we're going to talk about how you get around this in a minute. There are 2 ways. One is if the baby, the second baby right here, is born already having antibody of the mother attacking its fetal cells, then you've got to treat the baby. If, on the other hand, she hasn't gotten pregnant again, and let's go back even further. Let's say we're at the point right at birth, and she hasn't even made antibody yet. If you could block her from making the antibody, no problem. We're back to square one. She could have another Rh positive baby, no problem. Okay, so let's go to the problem. So here again is showing the mother's blood supply. This is the first pregnancy right there. Again, at birth, remember, you see 2 very different blood supplies here. Maternal here, fetal here. There is no mixing until birth. She has the baby. Some of these little fetal cells get into her blood supply at birth. She starts making antibody. Antibody, antibody, antibody. That's antibody to Rh. She's now pregnant with a second one, and some of those antibodies will cross over and cause problems for the baby during the latter part of pregnancy, the last trimester. So, again, our problem was Rh negative mom with an Rh positive fetus. If they're both the same Rh, not a problem. If it's an Rh positive mom and an Rh negative fetus, no problem. In case you're thinking, well, wait a minute, the cells of the mom, Rh positive, will go into the fetus, and will the fetus make antibody to the maternal mother? No, because the fetus has no functional immune system. Okay, so what I've described is called hemolytic disease of the newborn. Official name, erythroblastosis fetalis. Erythroblasts are cells with a nucleus. They're like a precursor stage, couple of stages before you get erythrocytes. They're easily identifiable. The bone marrow is spitting out red cells that are immature because so many red cells are getting destroyed in the fetus. So here are the main things that you need to remember. Okay, two things that we need to talk about. Treatment and prevention. I already kind of alluded to them. Okay, let's go treatment. We've got a fetus, and this fetus has already got maternal antibodies attacking its cell. It's born already. So we've got to do something for the fetus. What we're going to do is we're going to give it a transfusion. And remember that this fetus is Rh positive, right? But we're not going to give it Rh positive blood. We're going to give it Rh negative. And you're thinking, whoa, wait a minute. Now remember, there's maternal antibodies in the fetal blood supply, right? To the Rh marker. If we give the fetus Rh negative blood, there's nothing to react with those antibodies. It's a non-issue. Now, if you're thinking, okay, does the fetus now become Rh negative? No, because these Rh negative cells only last for a short amount of time. Remember, red blood cells only last a few months. And in the meantime, its own bone marrow is making Rh positive, so the fetus's blood gradually goes back to Rh positive. Okay, that's treatment. Now, let's go prevention. Prevention, that's aimed at mom. We want to stop her from making anti-Rh. So, in the mom, let's go back to a picture. I can't get back to the picture. Nope, can't get back. Well, anyway, remember that the mom, if we don't stop her, will make anti-Rh within a few weeks after the first exposure of the Rh positive agglutinogens of the fetus. So if we can stop her from making this, we have no problem. So what we're going to do is give her a material called Rogam. It's given by shot. It can be given during the last bit of pregnancy, or it can be given right after birth. This Rogam is antibody to Rh factor. GAM stands for gamma globulin. It's an antibody to Rh. It's anti-Rh. So if there's a fetal cell anywhere in the mother's blood supply, okay, fetal cell, fetal RBC, and there are Rh markers on the outside of it, this antibody that we give mom will find these cells and destroy them, take them out of circulation. So in other words, the mother's own immune system sees no fetal cells, sees no markers of the Rh type. Okay. So I took you through transfusion reaction symptoms before. One last thing. This is one thing I need to show you here. You saw most of this in transfusion problems, but I want to point out down here, kernicterus. Look at that bilirubin right there. Remember, it causes jaundice. But remember, it's carried around in blood, and if it goes into the brain, it can cause neuron damage or mental retardation, and that damage to brain cells is called kernicterus, with mental retardation associated. Okay, so let's move along now to White blood cells, not anything that I want to say. These are easy. You need to know percentages. You need to know what their job is. Just to point out, let's see, neutrophils. There he is. He's the dominant guy, 60 to 70% of all your white blood cells. He's the major phagocyte in the blood. And the other guy, who's the other major phagocyte, is a monocyte right there. He's about 5 to 10% of blood. Look how big he is. The basophils, this guy with the blue granules, histamine and heparin production involved in allergies, inflammation. And eosinophils, this guy right here, about 2%. Basophils are about 1% or less. Eosinophils are for parasitic infection control and allergic reactions. And the last guy is a lymphocyte, and he's about 20 to 30%. He's the second most common, and he's involved in immunity. So here's kind of a recap of what I just mentioned. Up here in the microscope, you got a worm, big guy, and he's surrounded by all these little cells, and you can just make out the word eosinophils. White cell production. Thymosin, hormone, involved in maturation of lymphocytes in the thymus. Remember the hormone EPO, erythropoietin, the comparable chemical that tells your bone marrow to make more differentiate white blood cells is called colony stimulating factor. There are different kinds. And I was trying to show you on the flow chart that the different white cells come from different stem lines. It's not important to know. Okay, too many, too little. Leukocytosis, excess. 50, 60, 80,000, way too high, usually indicative of a bacterial infection. The normal white cell count should be between about 5,000 to 12,000 per cubic millimeter. Too few, leukopenia. You're going to see penia again. That's a deficiency of. Viral infections very often destroy white blood cells. And then leukemia is a cancer involving them. Platelets. The name, other name they go by, thrombocytes. Thrombo means clot. You're going to see it a lot here. They come from bone marrow. Look at this big boy right here. He's called a megakaryocyte. Mega, for obvious reasons. Look at the nucleus. You can see it right there, but that's not the important part. Look at the cytoplasm out there, kind of a lighter purple. The cytoplasm disintegrates, and these little bits of cytoplasm go out into the blood, and that's what you're looking at right there. Platelets are little bits of cytoplasm that have been cast off from the megakaryocytes. So here's another look at sticky platelets. They tend to stick when they become activated. You can also see them again down here. There is a hormone involved in their production, thrombopoietin. Too few, thrombocytopenia. We'll talk about more. Okay, so here we get into the coagulation hemostasis material. Hemostasis, stopping blood from going out of the body in an injury. So here's the injury, cut, blood vessel. It could be a car accident, it could be cutting an avocado in your kitchen, whatever. Alright, so 1, 2, and 3. First thing, the blood vessel wall, there's muscle, by the way, in the blood vessel wall. When there's damage, oops, I didn't want to go that way. Alright, so once there is damage, the muscle in the wall contracts, keeps doing that, and the blood vessel gets smaller, constricts. You can see it there. That's the spasm. Second thing, okay, here's your cut blood vessel that you see right up there. Alright, here's the inside of the blood right there. Alright, so you see there's an erosion, damage of the blood vessel right over here. And that now attracts the platelets. Remember, the platelets are kind of zipping along with the blood going that way, or the other way, whichever. And they start sticking to this area that's damaged. It's called a platelet plug. Acts like glue that's stuck right there. Here's a platelet plug right there. Okay, the third mechanism, the most important, coagulation. These two mechanisms are stopgap measures. What really is going to stop blood loss is coagulation. It's a set of chemical reactions. It involves dozens of different things, proteins and minerals and vitamins and blah, blah, blah. And the proteins are produced by the liver. So when you have liver damage, whoops, didn't want that, it's going to affect your ability to clot blood. So down here, here's a normal old platelet, and here is a platelet that has started to stick, and you can see it looks different. I'm trying to erase things, but it doesn't want to erase. Okay, so let's go to the next thing. Okay, so now we're going to focus on the coagulation pathway. All right, the general pathway. All right, there are two ways to get into this pathway. It's like coming in two ways into your driveway. You can come in down the alley one way, you can come in down the alley the other way, but at some point when you pull into your driveway, you're now on a common pathway into your garage. All right, so let's do common pathway first. It involves a chemical, one of the proteins. No, I don't. Okay. Called factor X, comes again, it's one of the proteins made by the liver. It, when activated, causes the activation of prothrombinase, which is an enzyme. And that prothrombinase, let me erase that, this prothrombinase catalyzes that reaction right there. Prothrombin comes from your liver. Everybody in here has it, even if without clotting. And the prothrombinase converts prothrombin into thrombin. Now thrombin acts as an enzyme, and it causes this reaction to occur. It acts on fibrinogen, also normal, comes from the liver. It's inactive. I'm going to put an I there. When it's acted on by thrombin, it converts into an insoluble protein that looks like threads. It's called fibrin, and it's the fibrin that forms the clot. And all these little yellow things you see right up in here, these are the insoluble fibrin protein threads making the clot. Okay, now the details of the mechanisms getting into the general. All right, we've got two mechanisms, extrinsic and intrinsic. They both end in factor X, and then once factor X or factor 10 is produced, now you're into the general pathway. Again, it's like coming in your driveway two different ways down the alley. Okay, so let's go extrinsic first. Here's my cut blood vessel. All right, I'm going to change over to that. Okay, so we start out with damaged tissue. There it is, right there. These cells that are traumatized right in here make tissue factor. The tissue factor causes the activation of factor 10, which activates prothrombinase. You're now in the common pathway. Platelets were not involved in that. By the way, this is the pathway going that way. You can see there are quite a few more things I didn't mention, including, ta-da, calcium. All right, the intrinsic pathway. Look over on the right. All right, now this is where your platelets come in. Here are your platelets. I'm going to put blue dots right here. They are going to stick to the area of the wall that got damaged, right? This area right in here. Now, when you damage the wall, this is connective tissue, by the way, right in here. Collagen fibers are exposed, and they attach to the platelets, and the two of these together now result in platelet factor. That's this guy right here. And along with calcium and some other things, you end up again back at factor 10 and prothrombinase, and boom, we're at the common pathway. There you go. So, what do you need for all this? You need lots of things, but you need calcium. You need vitamin K because prothrombin, fibrinogen, a lot of the other proteins require vitamin K. Um, you got to have amino acids because these are all proteins primarily, and obviously you got to have a well-functioning liver. Now, this clot is going to obstruct blood flow, which is a problem because the tissue has to heal. And the organ that's at the other end on the other side of the obstruction has still got to get oxygenated blood. So that clot has to go away over time as the blood vessel wall gets repaired. So, again, take a look over here at the steps. The clot gets smaller, so to start to allow blood flow. But again, it's still present there. So we are going to go through a process of fibrinolysis, which literally means destroying fibrin. Again, that's what the fibers are. Sorry, I think that was my dog. Okay, so in your serum, you also have another protein called plasminogen. It's inactive. It only becomes active in the presence of a clot. And when it becomes active, it becomes plasmin. And it's going to now break down the clot. The clot goes away. The wall is now already repaired. Blood flow resumes normally. Everything's great. For people that have excess clotting, you can give tissue plasminogen activator, which will also enhance this. And obviously, you can also give anticoagulants. Okay, so about finishing this all up. Things that speed up clotting and make it happen more versus things that slow down clotting or inhibit it. Now, some of these things you can do on your own at home, and sometimes they're given to you in a hospital situation. Or sometimes they happen without either. All right, so blood flow reduction. You cut your finger, it's bleeding. The easy thing to do, you hold your hand up. Oops, trying to get rid of that bar. All right, so if you hold your hand up, you got less blood going to your fingers. Second, you can put pressure on the area, tourniquet, anything, or just hold it in your other hand. You can use drugs to stop it, like styptic and some things like that, which you can buy in little containers. You can put a Band-Aid on it, because frankly, fibrin thread's very similar to gauze. So those are all things that make clotting happen faster. Now, this thing is not something you want to happen. This is cholesterol. I'm just going to put CHO. So if you have cholesterol within your blood vessel, here's a longitudinal view of the blood vessel, and there's cholesterol obstructing the area, it forms big streaks of fat on the inside of the blood vessel. Platelets, I'll put P, start to attach here. And remember, once a platelet starts to attach, other platelets come in, and pretty soon you have a platelet plug, and then you've got a clot. Things that make clotting happen less, you can give anticoagulants. If you cut yourself, you can hold your finger under water. People do that all the time, but actually it makes your clotting less likely to occur because you're reducing the concentration of the clotting materials. You can also reduce clotting if you have a calcium deficiency or vitamin K, because your liver can't make the clotting proteins. And if you have really good circulation, you shouldn't have a clotting problem anyway. Okay, so we're about done. Problems, clotting and bleeding. Hemophilia, excessive clotting. Oops, didn't mean to do that. Oops, I can't get back. Genetic. But you can have other causes of bleeding. You can have aspirin that's blocking prostaglandins, and you can't get good clotting that way. Liver disorders. You can have too few thrombocytes And again, then you're going to have a problem with the intrinsic clotting mechanism. Or you can have the opposite problem, too much clotting, a thrombus, which is a clot attached to a blood vessel wall. And that's what you see right here in the picture. This clot is attached down here. Now, if it breaks free, by the way, this is called thrombosis, the condition. If it breaks free and it starts floating around with the blood, then you've got an embolus. And that condition is an embolism. And that's kind of frightening. Embolus, sorry. Let me respell that. Embolus. Because you don't know where that clot is going to end up. It could end up in the heart. It could end up any number of places. So, last thing, we've actually already talked about these, talked about different kinds of hemoglobin, talked about anemia. Pernicious anemia, remember, is associated with the elderly, usually due to an intrinsic factor or vitamin B12 deficiency. And that is almost it. This is the last slide. Hematological tests, the complete blood count, CBC. Anytime you go to a doctor, you get an annual exam, something wrong, they would do this. These are the main tests of the CBC, but there are a couple other ones also. And you can do clotting factors and blood chemistry. All of those can be used. So that should finish us up now.